So Retzius sparing has been out for a bit, and so I'm going to give you sort of some reflections on that. What it really is we had a very nice debate on this topic between myself and Dan Yoon at the WCE SIRS meeting in Paris, and Dan got to be the yes man, and I was the no man. So Khurshid Ghani, of course, put it on social media. This is me in the back row waiting my turn while Dan gives his talk here. But I like the Twitter response. One was sort of a question about the positive surgical margins we'll get to. And then David Cans had this nice talk, quote, "Nothing catches on in surgery more than what is more technically difficult than the preceding procedure." So yes, we love making things harder than they have to be sometimes. So these are Dan's slides on the topic. The Bocciardi technique, of course, started with a case series and feasibility type of data, even some honest failures of attempts on these type cases. And it depends on how you code this. I mean, I currently don't do a full Retzius sparing, but I'm good at the posterior mobilization. I'm interested in this. And I certainly can get the pedicles down and get some of the nerve going, and then I basically turn north to the bladder neck and I get a little bit lost. And that's not a big deal because I just flip it around anterior and finish it normally, and there's a whole lot of progress underneath. So I'm not really putting patients into like a different procedure category. But you know the route and probably have seen examples of it, starting posteriorly in the pouch of Douglas, and a lot of our trainees like this setup anyway, so the only difference is doing pedicles and then getting through the learning curve of bladder neck. And as you'll see in the slides, you're upside down, and then you're right side up, and then you're upside down again. So that's kind of the challenge of it. This is a video clip we put together. So the pros, of course, the anterior space is untouched, as it would be with perineal single port that's coming up on discussion. Bladder neck preservation, DVC preservation, nerve sparing, I'm sure you can dial that up and down as you prefer. The cons, and I'll get to this more in my talks as well, is minimal landmarks, yet another learning curve to go through, visualization challenges, collisions potentially. Anastomosis, again, is upside down, and you can't see the retal orifices. I don't know if anyone saw the plenary session with Dr. Torar and everyone yesterday. We showed a duplicated ureter, where the ureter was back down to the last 3 millimeters possible to excise within the specimen. I don't think you would have seen any of that posteriorly unless you were lucky and happened to image the patient. Bladder neck reconstruction, of course, a little bit difficult. And most of the trials and data is sort of excluding large prostates and high BMI patients. So then this sort of developed, and you need a second person. You know, someone proposes, someone is a second. So I think I would credit Kuhn Ra for that. And boy, does he make this easy looking. You know, these are 30-minute and less resection times. At this point, he's done over 1,000. He published the early series, sort of replicating the Bocciardi technique. You saw this publication in BGOI International. It's already 5 years old. And then you move on into the Henry Ford trial. Now that was a team, you could call it the Menon trial, but it was a team effort. There were multiple surgeons involved. So they randomized anterior versus posterior, looked at short-term continence. This is the early Platinum Journal publication. Then with additional follow-up, it went to the White Journal, and I think these curves sort of summarize it the best, that yes, you did have some early return of continence that sort of calmed down over time. So your best benefit was in that early 3-month window. Potency was competitive between the two as well. So are there superior functional outcomes? Potentially, they're perhaps short-term compared to the conventional approach. And then this was sort of my contrary opinion, if you will. Main issue is, again, the learning curve. The anatomy is upside down, then it's back. You know, when you do the urethra and apex, there's a way to approach that to you're looking down on it. Ra actually kind of simulates that view, actually, because he crawls around the side of it and does the urethra almost from its side edge, leaning north. So it actually looks kind of normal, just like you'd put a weird 30-degree lens on it or something. You do have issues with assistants having challenges, and so you see different technical ideas of suture retraction, what have you. Everyone, the issue is there's the talk of the procedure and then there's what's in the literature. Everyone who's done it talks about perhaps some misadventures into the ureter, positive margins. And yes, you can reach the lymph nodes, but then you're sort of taking down some of that space if you're going to do that. And here's, I think this is, I should have bolded this. I don't think we really know the learning curve of this procedure in a broader group of surgeons, like normal volume surgeons. We have the experience in unbelievable volume surgeons. Maybe that's different, maybe it's not. So the question is sort of, should you do it? So, and is it a valid association? I've always wondered this, and no one really knows the answer. If this is such a magic bullet for continence, then how come perineal prostatectomy didn't figure this out 20, 30 years ago? Maybe we didn't ask the right questions, perhaps. And there's other ways to keep peritoneal instruction. You know, think about open prostatectomy. You're leaving the peritoneum up. You put a drain in there, that thing should suck down in a few days, really. And if you've done salvage node dissection, it's impressive how much that whole space recreates itself. You don't know the time course. The only thing I would say is if you fully drop the urachus down, it reestablishes itself downhill a few centimeters. I don't think that matters or not, but you can easily spare the urachus and work around the side, and perhaps that reheals. And then you look at this bullet list of all the other ideas people have put out there that improve continence, potentially anterior suspension. As I think Bedard Mian said it on social media, it seems like anything that supports anteriorly is supposed to help, whether or not it's the SP tube, anterior plus lateral reconstruction from Professor here. Rocco, I think urethral length is a big deal because that's just anatomic sense. Ligament studies, and you know, we all get better every time we do another 100 cases. So the group from Guys asked me to assist on this comment we put in BGOI, and that looked a little more deeper into the margin rates, not statistically significant, but a slight trend from, this is sort of an analysis of the Henry Ford trial and some of the, you know, the other alternate ideas. And some people have even written feasibility studies of just reconstructing the Retzius space if you really thought that was important. I had some training observations that I took out because it's only a 10-minute talk, but I like this slide, and I show it to some of our interviews for the fellowship to try to talk to them about the transition of going from a trainee and a novice surgeon to an expert, and this is kind of what we're looking for in their progress. It's sort of 3 bullet points. Expert surgeons know ideal exposure, and they know how to fix it immediately. Novices tend to work longer and in poor exposure. So what happens when you take an expert and put them in small exposure? Well, you have fewer options to fix it other than getting out of Dodge and changing to the traditional approach. What about recognition of planes with minimal feedback? Well, if you're going to change your sequence of the operation, all of a sudden that efficiency of plane recognition may start to dull, and you actually might start making mistakes again, potentially. Although it's sort of another way of saying it, you can, when you do a lot of these, you can sort of see anatomy before it can be seen. I know Dr. Patel's going to come up here and talk about his experience. Every time he does a live surgery, it's amazing how much he just knows where every blood vessel is and doesn't cut into them, so you get these dry cases. And if you think that's a live surgery effect, go see him in Orlando and you'll see the same thing 8 times right in front of you. Dr. Twire is unbelievably dry as well. Does that change when you suddenly disorient them and put them something differently? And that's kind of what we probably would strike with. So I had struggled with becoming a novice again. I worked hard to get past it, and it's hard to make me want to do it again. Here's your example of course, Retzius space reconstruction. And I wanted to just wrap up this short talk and just saw, yes, small gains in early continence. If you're good at it and you like it, I think it can be safe. Impact on oncology outcomes is clear. Is that really unclear other than the learning curve issues? Training we've talked about. Yes, this could be appealing market-wise, and you know, Kun Ra is very honest about this. In Korea, people pay out of pocket big time for these procedures, so he would argue that 3-month gain is a big deal, and he's passed the learning curve, so that's appropriate. Does still require intraperitoneal access, as opposed to what Dr. Joseph said. And as sort of a new information update, there's a little earlier discussion amongst single port users that single port actually may solve a little bit of the exposure issues because you don't have to have assistance coming in from the side. So it'll be interesting to see if the early users re-tackle that. So again, single port's coming, and so there's other learning curves out there waiting for you should you wish to venture. So thank you very much.